Welcome to Creating a Family. Talk about foster, adoptive, and kinship care. I'm Dawn Davenport. I am the host of this show and the director of the nonprofit creatingafamily.org. Today, we're going to be talking about evaluating risk factors common to domestic infant adoption. We will be talking with Dr. Lindsay Terrell. She is a pediatrician at Duke University Medical Center and an assistant professor in the Department of Pediatrics. She is the clinical director of Duke's Foster Care Clinic, and she and her husband are also licensed foster parents. At the end of this interview, we will also be talking with James Fletcher Thompson. He is a South Carolina attorney with extensive experience in the legal process of adoption as well as assisted reproductive technology. He's a frequent lecturer throughout the country on adoption as well as child welfare issues, and he is the author of the book published by the South Carolina Bar entitled South Carolina Adoption Law and Practice. He has received national and state recognition for his service on behalf of children and adoptive families, and he also serves on the board of Creating a Family. As I said, we will be discussing the legal risk factors with Jim at the end. But we were going to start with Dr. Terrell talking about some of the common risk factors in domestic infant adoption. And when I say this, I mean medical and mental health risk factors. I want to start with the lack of prenatal care. Very often we see that expectant women, for a variety of reasons, have not had prenatal care. I think that's something that worries adoptive parents. So, Dr. Terrell, what is covered in prenatal care, and how might the lack of prenatal care impact a baby?
Right. Thanks, Dawn. Thanks for having me today. I'm looking forward to this conversation, and I'm also looking forward to the conversation to follow as well, and all of the legal risk factors. But so let's start with just what's covered in just general prenatal care for a child or for a mom and a baby, right? So I kind of break this up into groups. I think about the first step is just general health assessments and monitoring for mom, right? So that includes things like blood pressure checks to make sure that mom doesn't have high blood pressure or gestational hypertension or preeclampsia, right? Those are all things that can really complicate a pregnancy. Things like urine tests are done to check for signs of protein or glucose, which would be an indication of gestational diabetes. Monitoring for infections. For example, urine infections can be not something that you want during a pregnancy and can lead to complications. Weight monitoring, blood tests to check for certain infections, as well as anemia and blood type, which can put that baby at risk for some things later on as well. And then general screening for genetic conditions is also a routine part of overall kind of monitoring of mom. Then the next step of this prenatal care is really thinking about the growth and development of the baby. And so during some appointments, but not all, ultrasounds are completed to check for fetal growth, monitoring that baby's position, checking for any abnormalities that they may see on the baby. At each appointment, they measure a fetal heart rate or heartbeat to make sure that that baby's heart is beating in the rate that it should. We think about fundal height, which is measuring how big the uterus is, right? Which is an indication of how big the baby is. And so those are kind of the two big categories that prenatal care would be broken up into. But then you also think about what else goes into those appointments, where that OB would be talking about nutrition and lifestyle counseling, things about how to eat, how to exercise, lifestyle modifications, don't drink alcohol, don't smoke cigarettes, try not to eat raw tuna, all of those things that go into those regular prenatal care visits. And then you also think about vaccinations, preventative care, as well as monitoring any chronic health condition that mom may have, right? Not all moms coming into pregnancy are healthy, and some medical conditions can complicate or add challenges to pregnancy. And so making sure that that is done well and under good monitoring is an important part of a healthy baby being developed and born.
So if a mom hasn't had the advantages of having this prenatal care, how does that impact the fetus and then ultimately the baby?
Right. I think in the medical world, we generally say a lack of prenatal care can lead to really significant and serious complications in that baby. And you can imagine that without good prenatal care, it could become difficult to identify or address any complications that may be present or may come up during that pregnancy. Now, is it possible to have a totally healthy, wonderful baby with no prenatal care? Yes, that's possible, hoping and assuming that there are no complications that come up, but that's a gamble, right? And in our world, and especially in the United States today, we have great prenatal care to offer to try to help and pick up some of these complications. And so without prenatal care, what we know is that babies are at increased risk of preterm birth. You think about, normal deliveries at 40 weeks, preterm is before 37. And so in general, research shows that if moms are not getting routine medical care, they are more likely to have a baby born preterm. That can lead to complications, which may include breathing problems or feeding problems or behavior problems or even long-term problems. So kind of a wide range of what could happen from that. Also, moms with little to no prenatal care are more likely to have babies with low birth weight. And we think about generally like 5.5 pounds or more is kind of in that normal category. Below that, you're thinking low birth weight. And so they're born small, but again, similar complications as to the preterm birth when you think about respiratory problems, feeding problems, or ongoing developmental delays later in life. Now, I say all these things, it doesn't mean you're guaranteed that, right? We're just talking about general risks. I want to make sure that everyone who hears this doesn't get scared away by saying, oh no, well, no prenatal care means all of these problems. It doesn't mean that. It's just a higher risk. Other things to just think about with little to no prenatal care would be screening for those infections and overall health conditions that might be missed, screening for babies' health conditions, so genetic abnormalities or congenital abnormalities that baby may have that would normally be picked up in routine prenatal care may not be picked up until birth. And even then, some of those things can be a little tricky to pick up at birth. And so I would want to make sure that you have a good pediatrician and that baby is getting good care to make sure that all of the things that should have been screened for early are being checked out well. Doesn't mean they're going to screen for everything once the baby's born, but just being thoughtful about listening to that baby's heart and doing a good physical exam on that baby and making sure that baby has developed as normally as possible. And then, I think the biggest risk of, or kind of the scariest of lack of prenatal care is just this risk of stillbirth, right? It's much higher if a mom is not receiving prenatal care. And so, again, that's why I think the medical world would really push that every mom have access to really good prenatal care. And then I just think about as a mom in general, it's hard being pregnant. And there are a lot of emotional changes. And, especially if you're a mom who's thinking about adoption, that prenatal care, I hope, would offer you some support for education and mental health support as you're thinking through that. And so for moms who aren't getting that, where could they get that support in another way? It's just something to be thinking about.
Right. And as you say, generally speaking, once a mom is making a decision to place her child, if she is in contact with an adoption agency or an adoption attorney, at that point, usually she is then beginning to get the prenatal care.
Right. And I think it'd be interesting to just poll the audience and say, do you think that if a baby's being put up for adoption, they'd have limited to no prenatal care, thinking like that mom doesn't want them. And I think it's important to know it's so individual based on how that mom's doing and what they're thinking. There may be children or babies that are where mom is deciding adoption and she's had great prenatal care the entire pregnancy, and she cares so deeply for that baby. And so
it is usually issues of poverty.
Yeah, it's not about caring.
It's not about caring. It's not about love. It is about a chaotic life, a busy life, just a lot of different factors.
Right.
Let me take a moment right now to ask a favor of you. We really need you to rate or review this podcast. It really helps us when you do. That's how any of the podcasting apps make recommendations. It could be a star rating or it could be a written review. Either one is really helpful for us. And of course, subscribe to the podcast if you're listening. That goes without saying. And recommend it to friends. But in addition to subscribing, which is probably the most important, if you could please rate and review this podcast, it would really help us. And now you can get back to this interview. All right, now I want to talk about another risk factor that can come up with domestic infant adoption is prenatal exposure to alcohol and drugs. Again, it is not universal. However, it is also not uncommon. So we're going to start this section by talking about the short and long-term impacts for alcohol. Then we're going to move into talking about opioids, and then we're going to talk about other drugs that are commonly abused in the U.S. All right, so let's start with alcohol. What are some of the red flags that a mom might have abused alcohol during her pregnancy?
It's such an interesting question. I was trying to think, again, breaking up into two pieces. One is just trying to understand mom a little bit more. I'm trying to put myself in the perspective of maybe a bio mom has just chosen me as a family, and maybe I have a little bit of a relationship with her. I'm getting to know her. Risk factors I would think about would be, right, obviously past use of alcohol or an alcohol abuse situation that, I hope moms would be able to talk about and free to talk about if that was true. A history of substance abuse in general, or polysubstance abuse, where a mom is using so many substances that you would worry that they're all at risk, right, including alcohol. Those would be things I would think about for mom. But then once that baby is born, there would be certain things that would make you worry that maybe that baby had alcohol exposure. And that would be things like growth restriction, or that baby being smaller than what you would expect. And then there's certain, fetal alcohol syndrome is this big term, and it can be challenging to diagnose. But typically what we think about with fetal alcohol syndrome, there are facial abnormalities that come along with that as well. And so sometimes when that baby is born, a physician can do a physical exam on that baby and have concern for that. Mm-hmm. As far as I know, there's no real great way to slam dunk diagnose it. You kind of have to watch how that baby does over time. But there are certain things, growth restriction, facial abnormalities. And then as that baby grows up, if there are developmental delays, all of that could at least indicate a concern for exposure to alcohol in utero.
Mm-hmm. And I'll just throw out that the classic facial abnormalities are fairly rare, mm-hmm. and therefore the absence of those does not mean that a child has not been exposed.
Correct.
Does the degree of impact differ depending on when in the pregnancy alcohol was consumed?
Yeah, so that kind of, as you said, right, that it makes sense to me, and what we know from literature is that the earlier on you're exposed to alcohol, the more likely you would be to have those facial abnormalities, mm-hmm. right? As your face is developing literally inside a mom. And so earlier on during pregnancy, that consumption of alcohol can lead to more of those deformities or changes in facial appearance, but also changes in baby's organs as well. You think about heart defects or other birth defects that can be affected when there's a chemical actually in there that shouldn't be in there. And then when you think about second and third trimester, so later on during pregnancy, that face is not developing, the organs are already developed, but the effect of alcohol on the brain and overall mm-hmm. body of that baby is still very much a concern. And so alcohol later on in pregnancy, you start thinking about posing a risk on the baby's development, learning difficulties, attention things later on in school, or even, and more short-term, baby being born small, mm-hmm. Maybe having trouble feeding and that kind of thing. And so there's a whole spectrum of this fetal alcohol syndrome. And so, as you said, some of them may be more visible, but some, and I would say even in our clinic over the past 10 years, we've maybe seen one or two children who have really concerning features of fetal alcohol syndrome. And then we've seen many, many others where we're concerned about exposure to alcohol mm-hmm. in utero, but there are no abnormalities or facial abnormalities that would come along with that.
Yeah. And for more information on this, Creating a Family has a terrific workshop that we put on for parents. It's the Prenatal Substance Exposure Workshop for parents. I'll include a link in the outline to that, but it's a 3-session in-depth of what to expect, and most importantly, what works. How do you help these kids? How do you help these kids thrive?
Yeah, that's great that y'all do that, Dawn.
Yeah. All right. Now, moving on to opioids. One of the challenges on prenatal substance exposure in general is that alcohol is very difficult to test for at birth. So very
Mm-hmm.
often we're guessing. We don't know. And honestly, even if a mom comes in to labor drunk, if she says, I just did this because I was trying to cope with the labor pains, you won't know. And it metabolizes so
Right.
quickly in our bodies. Therefore, it's almost impossible to test at birth. So you're not going to know. However, some of the drugs we are now moving to talk about, and opioids is one of them, it is possible to test. So you may know that a child has been exposed. So, what I'd like to do is talk about some of the opioid drugs. And I've made a list of drugs that are used at increasing degrees of strength and that a mom may have taken during pregnancy. And I'd like to talk about what we know as far as the impact. What's research telling us as far as the impact, both short term, but really more long term, because we will talk about NAS and now in a minute. I don't want to talk
Mm-hmm.
about that necessarily now. So codeine is, I actually didn't realize it was a lesser strength, but apparently it is.
Mm-hmm.
Codeine, and then some of the Vicodin ones, which are hydrocodone, and then maybe morphine. So let's talk about some of those. What do we know about the impact of these less strong opioids?
So I would say for those, like the lower potency opioids that you spoke about, those are all, they should be prescribed medications. You can get them prescribed by a doctor. So I typically, when I think about those, I'm thinking about, someone who's having tooth pain or just had a root canal, or maybe they had a arm fracture and they need a little something. So all of these prescription opioids, hopefully, are being given under the care of a physician. They still pose some risk, right? But hopefully a physician is monitoring the amount and the duration that mom is getting, and therefore limiting how much that baby is being exposed to. Even with prescribed opioids, such as the one you said, there still can be some risk that can come with that, including, I know you don't want to talk about NAS yet, but neonatal abstinence syndrome, depending on when that is during pregnancy and related to delivery, can still have an effect. But overall, in terms of the effect on that baby, it should be relatively low.
Okay, excellent. Yes, and we can throw in neonatal abstinence syndrome, NAS, or neonatal opioid withdrawal syndrome, NOWS. So it's possible, but because usually these are not being abused as street drugs, although that can happen, but that's not the common one. If it's under prescription from a doctor, what I'm hearing you say is that the risks of long-term impacts is lower and the risk of NAS or NOWS are lower as well.
Correct. And those can also be misused, right? So someone could get a prescription and misuse that, or someone could sell them on the street and they could be used as street drugs, which would make it more concerning about what it is that you're taking. Typically, if they're being used in a street drug kind of fashion, and this is anecdotally from just being in clinic and having experience with some of these children, is that those drugs are being used with higher potency when they're on the street. So the street drugs are mixing in more of the higher potency one and maybe filling in the lower potency one just on an as needed basis. And so
Gotcha.
I'm not minimizing that they can be used in street drugs, but typically the higher potency one are more kind of the heavy hitters in the street drug category.
All right, so we'll move to the heavy hitters. That would be some of the oxycodones, which would include Oxycontin and Percocet. And we'd also have Dilaudid, which is hydromorphone, I believe.
Mm-hmm.
I'm going to hold heroin and fentanyl to talk about in just a minute. So let's talk about some of again, these are often prescribed, but they're also often used illegally as well. So what do we know about the opioids such as Oxycontin, Percocet, and Dilaudid?
Yeah, so all of those, right, they're higher potency. So you're at higher risk of that baby having that addicted kind of feeling, right? It's just a little baby, but they still have that. If they're exposed over a long enough time, it's more likely that they're going to have that addiction type level of need for that drug.
It's a physical dependency, isn't it?
Yes, the dependency. And so this neonatal abstinence syndrome, NAS or NOWS, as you said, is that dependency. So that baby is born and prior to being born was getting these hits of these opioid or narcotic drugs. And then once that baby's born and that umbilical cord is separated, they all of a sudden have a cease withdrawal of all of those drugs. And it would be just like an adult going to a rehab program and experiencing the withdrawal of that medication. And it must be miserable. It sounds like it's miserable and awful for adults. And babies can only really do one thing to express that, and that's be incredibly fussy, which interrupts feeding. They can have really irritable digestive systems. One of my favorite little places in the NICU is where they keep babies who have been exposed in just this very dark, quiet room. And there are all kinds of protocols to make sure that you don't disturb them. So when I think about those, I guess we'll call them medium potency, but they're still pretty high potency. Most of those are still prescribed. I think all the ones you said are still prescribed by a physician. So hopefully it's just a short-term thing and they're prescribed by a physician. Maybe a mom has a slip disc or something during pregnancy and she gets a couple of doses of Dilaudid. That's great. But if it's being misused or overused, then you start to think about, okay, symptoms short-term when that baby's born. But then you also have to start thinking about the longer term complications, which can obviously vary on the dosage and the duration, but you start to think about kind of all of the ones we mentioned before. I mean, you can have things like birth defects, problems with organs, so, congenital heart problems or other organ problems, but then you also start to think about just overall growth and development for that baby and behavior concerns and predisposition to certain mental health problems that, long term, we just need to be thinking about. Again, it doesn't guarantee it, right? But the risk factors are there.
All right, now let's talk about heroin and actually even more important, fentanyl, because that is replacing in so many ways heroin. What do we know about the impact, both short and long term, of a mom? And these are most often being abused illegally.
Yeah.
So what do we know about the risks of NAS and NOWs as well as the long-term impact of a mom who's abusing heroin or fentanyl?
And I would say anecdotally, fentanyl and heroin are all what we're seeing most of right now in this.
Okay, that's helpful. Thank you.
Pandemic of drug exposure and drug addiction that's out there. And so obviously heroin and fentanyl have the highest risk of all of these things that we had just talked about. And so if a mom has been using fentanyl or heroin throughout her pregnancy or with limited support or limited, access to drug rehab programs, then short term, you could likely expect that baby is going to be born with dependency type symptoms or this NAS or NOWs kind of symptoms. And what that looks like to someone who's not medical is an incredibly fussy baby who gets disturbed pretty easily by light or sound, has an upset GI tract. Feeding may not be super comforting. Things like really watery, loose stools or diarrhea can accompany this as well, vomiting, spitting up. And so all of those things are tracked. When that baby's born, it's tracked in the NICU. There's a whole scoring system. And if the baby's score is too high, then they actually get a little dose of morphine. And so hopefully a baby could make it through that period without needing any additional medication. But sometimes babies who are really experiencing those symptoms actually need a little dose of a medically prescribed opioid to taper down those symptoms over time, in the same way that an adult would receive Suboxone or methadone to help relieve some of their symptoms. And so that's the short-term complication. And I think once that baby makes it through that period, which can last days to weeks, depending on the half-life of the substance that was being used, once they make it through that period, they might be a little more irritable than the average baby. They might have more feeding trouble than the average baby, but typically they make it through that horrible first stretch and they kind of would look and appear more like a baby who has not been exposed to substances, if that makes sense.
Mm-hmm. It does.
Then you got to think about the long-term consequences from that. And, our medical field is still learning so much about this. And unfortunately, we're still in this crisis of substance abuse that I think we will still be learning about this for years. But the typical things to think about for a baby who is exposed to these higher opioids throughout their pregnancy, you think about developmental delays, cognitive impairments, behavioral issues, an increased risk of learning disabilities. It may affect the child's motor skills or attention or overall, cognitive functioning. And the severity of that can just depend on the amount and duration and when those opioids are used.
And the temperament and the genetics of the child itself.
Right. It's so unknown.
Mm-hmm.
And I've seen many babies who are exposed to many substances and they're doing great.
Right.
And I've seen some who are exposed and they struggle more, and maybe feeding is an issue, or, behavior is an issue. Or I will say too, I think it's important to know that even if a baby didn't experience that really hard newborn time, that NAS or NOWS, it doesn't mean that they won't have the long-term effects.
I'm so glad you say that, because I think that's almost a universal misperception of everyone, but in specific to prospective adoptive parents. We hear it all the time. They weren't born dependent, or they didn't have NAS or NOWS. Therefore, I think they're not going to have any impact. It's not connected. You could still have an impact regardless of whether the child was born dependent.
Exactly. And the same thing is true. You may have a really hard infant period and then no long-term complications at all. And it helps me to think about this like naturally during the birth process. Let's just say I'm a mom, and 4 weeks before my baby is due, I take fentanyl every day for something. Maybe I'm having horrible back pain or something. My baby would be born with likely NAS or NOWS. Like that would be very hard for that baby. But they were just exposed for the last 4 weeks of pregnancy. The likely long-term complications are hopefully not as much. Whereas I could have used fentanyl up until my 36th week of pregnancy and then gone through rehab and detox. And then that baby would be born already detoxed, because he or she went through that with me in my belly. And so at that 40-week mark, when the baby's born, the baby actually looks and seems okay and is not irritable and not fussy. However, they had 36 weeks of fentanyl prior to that during really critical developmental periods. So, trying to think through that logically sometimes helps me understand how that could be.
That makes perfectly good sense. Well, the way I think of it is the baby went through the withdrawal in utero is what happened.
Right.
And so we're not seeing it on the outside. All right. Another very common question is moms who are going through medical treatment for substance abuse disorder and are being given methadone, Suboxone, and there may be others now as well. But it's part of a medically prescribed treatment to help them with their substance abuse disorder. What do we know about the impacts of these drugs that are utilized to help moms cope with substance abuse disorder?
So, I think about methadone and Suboxone similarly to like prescribed other opioid medications. If they're being taken well in the way that they're prescribed and they're limiting all of the other higher, scarier opioids, that sounds really good, right?
Right.
Now, are they without all risk? No, right? Suboxone and methadone definitely carry some risk, but I think the risks are relatively low, and overall, compared to the other opioids, are in a much safer category. Now, a baby who's exposed to Suboxone and methadone throughout the length of being in that mom's belly will still likely be born with that NAS and NOWS syndrome, right? Because both of those medications, methadone and Suboxone, are long-acting opioid medications. And so the way they work is the person takes a dose of it and it kind of lowers the need for another opioid. It just kind of lowers that threshold. And so it's this long-acting opioid. And so the half-life is long. And so when a baby is born exposed to Suboxone or methadone, that period when they're born where they're having these neonatal abstinence syndrome is usually quite longer than a baby who's born exposed to fentanyl, where that half-life is quick, because the half-life of Suboxone and methadone is so much longer. So in the hospital, when a baby's born exposed to methadone and Suboxone, we kind of have a general idea. You may not see the symptoms until 2 to 3 days after that baby's born, because the half-life has to get low enough where that baby's actually missing or needing that, depending on that medication. And then typically those symptoms may last a little bit longer. So that risk for the neonatal abstinence syndrome is still there with those medications, but the longer term risks are lower if that mom can maintain those medications instead of the other scarier opioids.
And does the degree of long-term impact You've already mentioned that the risk of short-term, NAS or now, does depend on when in the pregnancy the opioid was used. If the mom has stopped, the baby goes with withdrawal in utero and so does not have NAS or now. But what about the long-term impacts? Does the degree of impact long-term depend on when in the pregnancy the opioid was used? If the mom used and then realized that she was pregnant and got into a treatment facility, at when she was 4 months pregnant versus a mom who, for whatever reason, either picked up using towards the end of her pregnancy.
Right.
Do we have any information on that?
I would say maybe my information is more anecdotal, that the longer that mom has been clean and using methadone and Suboxone, the better, and the lower risk of kind of bad outcomes later on, or I shouldn't say bad, longer term outcomes. You may know more than me, Dawn, about specifically methadone and Suboxone and what research shows just for those medications. In clinic, we see it's rarely just those meds. Unfortunately, substance abuse is just a disease that people go in and out of, right? Depending.
Right.
And so there might be some use early on and then Suboxone or methadone, and then some more use in Suboxone and methadone. And so in my mind, the more Suboxone and methadone that there is with just those medications, the happier I am and the more hopeful I am that child can go on and have as healthy of long-term outcomes as possible given the situation to begin with.
Let's move off of the opioids. You've also mentioned that cocaine was another drug that you commonly see abused. So what about the short-term impacts of cocaine? Primarily, we're thinking NAS now or just a fussy baby, and then the long-term impacts. And maybe there's more research on this because cocaine's been around and abused for a longer period of time.
Yeah, that's a good question. I typically think about cocaine in the same way that I do heroin or fentanyl. And typically there's quite a bit of overlap there. And so, I think the hardest thing about cocaine, unlike opioids, is there really isn't an antidote to make someone feel better. So if I'm addicted to fentanyl, Suboxone and methadone can lower that threshold for me. If I'm a baby having been born exposed to fentanyl, morphine can be given to kind of lower that threshold of my fussiness. Cocaine, unfortunately, just doesn't really have an antidote like that. And so babies that are born exposed to cocaine just have a similar and very incredible fussy period. Similar stuff, abscess stomach, all of the things, feeding difficulties, low birth weight, all of the things I said that apply to opioids. But there really isn't anything the health system can provide to help lower those things, right? You really think about babies born to cocaine really needing that swaddle, quiet, soothing, low stimulation environment for short term. And then for long term, all of the things that I mentioned for opioid, the heavier hitting opioids, including long term behavior and cognitive challenges, are also true for cocaine.
Something that I know is increasing, and I think it's going to increase even more, is marijuana usage as legalization. And I also think that pregnant women are sometimes thinking, well, I shouldn't drink, but it's okay for me to vape, smoke, or eat edibles with THC. So what do we know about the short and long-term impacts of kids whose mom have used marijuana during pregnancy in any of its forms?
Dawn, I have to say I'm probably not as familiar with just overall infant exposure. We see it a lot. You're right. It's just out there. People are using marijuana a lot more than usual.
And there's not the public service campaign about don't drink when you're pregnant. There's not that for don't use pot when you're pregnant.
Right. What I think about marijuana is that it is interacting with your brain. It's a substance that interacts with your brain. And so it would be understandable that in a developing brain and nervous system, that introducing that chemical could cause trouble, right? And we know this with teens and adults who use marijuana long term. Their brain actually does change a bit. Their overall ability and desire to do things and their appetite, all of that can kind of change long term. And actually, people who use too high a dose of marijuana or too much marijuana over a long time can have marijuana-induced psychosis, right? We know that marijuana can very negatively affect your brain or affect some people's brains. And so I think we still have some learning to do about that and what the long-term consequences of marijuana are. Now, when I'm just going about my regular day, and this is some of my favorite part of my work, is someone will call and say, hey, I'm thinking about fostering this child, or I'm thinking about maybe a adoption, a local or in the U.S. adoption of this baby, and here are the risk factors. Marijuana doesn't worry me too much, right? Mm-hmm. But when I hear heroin, cocaine, fentanyl, I worry a lot more. And so it doesn't mean it's no risk at all, but it's in the same category of eating too much sugar. Like if we're ranking risks, it's in the lower of the high risk.
Yeah. And the last one I just want to ask about, because we used to see it, I'm not sure how much we're seeing it now, and that's methamphetamines. I don't know how common it is right now, but what are the risks that you worry about with meth?
Yeah. So meth is similar to cocaine, heroin, and fentanyl. You think of general pregnancy complications that can include low birth weight, being born early, being born with feeding problems, irritability, trouble growing, right? Meth falls in that same category. In addition to that, when we're talking about things that we're inhaling or injecting, we got to think about concern for other infections too. So just be thinking about that as well. But then, with meth, similar to cocaine and fentanyl and heroin, those longer term outcomes are very similar.
Okay.
And again, like hard to know. And so much of what we're seeing now is really this polysubstance abuse. Substance abuse must be so challenging because your body's so dependent on these drugs that you're willing to get what you can from who you can get it from. And maybe that's presumptive for me to say, but it seems like the use of multiple substances is more common than the use of just one, unless it's being prescribed by a physician.
We see that as well. And I throw in alcohol with there as well. And something that I think the general public is not aware of is that from the long-term impact, alcohol is by far the worst of all. It's counterintuitive because it's legal, but the long-term impact is the most. And for those people listening, let me also say that Creating a Family has extensive resources to help parents parenting a child exposed to opioids, alcohol, or really any of the drugs. There are definitely techniques, there are definitely things that work, especially if parents are aware going in and are looking for and getting help quickly and getting a child diagnosed quickly. So it's not all doom and gloom. There are things that can be done, but part of it, our challenge is making sure prospective adoptive parents or foster parents go in with their eyes wide open.
Right.
Let me interrupt this interview for just a moment to tell you about the free courses we are offering to you through the support of the Jockey Being Family Foundation. We have 15. They are really terrific courses. If you need a certificate of attendance, you can get it. If you don't, you don't have to, but you could still take the courses and learn the information, and they really are great. So you can jump back now to the interview, but don't forget the Jockey Being Family courses at bit.ly/JBF support. All right. Now I want to move to talking about the risks for sexually transmitted infections. So first, what are the common STIs, sexually transmitted infections, that are seen most commonly now with pregnant people?
Right. So I think that STIs that people are most familiar with are things like gonorrhea, chlamydia, trichomonas, right? Those are the kind of low-hanging fruit ones. And then you think about maybe the more scary ones. I'll put syphilis in its own category because unfortunately we're seeing a pretty big increase in syphilis across the United States. It's totally preventable. It's also treatable. And so that's why I put it in its own category. Gonorrhea, chlamydia, trichomonas, also preventable and treatable. And then you have herpes and HIV. Herpes and HIV, right, are preventable. They're treatable, but not curable. And so typically there's kind of a stigma that goes along with those, which I'm excited to talk about, probably HIV the most out of everything. But yeah, so those are the STIs that I think about when I think about, and I'm going to drop trichomonas out of there because it carries a little bit of risk, but overall, it doesn't carry the risk that the other ones do.
All right. So what are the risks? Let's take each of them. Let's start with gonorrhea and chlamydia. What are the risks to the unborn child or the newly born child? Because as I understand it, some of the risks accrue as the child passes through the birth canal
Correct.
and is exposed, but some of the risk might have to do with the child in utero.
Right. And so we should think about risk as how long that baby has been exposed or that mom has had this disease, right? If they have it for a day or a week, probably a pretty low risk. And that's why prenatal care is important and getting medical care when there are problems is important. So when I'm talking about the risk for these, I'm talking about kind of untreated gonorrhea and chlamydia that maybe has gone on for some amount of time. So those infections, you'll hear me kind of say the risk during pregnancy for a lot of these is the same. The risk for preterm birth goes up, low birth weight, or the risk of a baby being born smaller than it should be also goes up. And then what you really think about for gonorrhea and chlamydia specifically is that when that baby's born through that birth canal, they're exposed to that gonorrhea and chlamydia, and that could lead to a neonatal infection of either gonorrhea and chlamydia. And, I think people know that when a baby's born, they get their vitamin K shot, they get their little eye drop or the eye ointment. That's actually prevention or treatment of a gonorrhea infection in their eyes. And so in third world countries where prenatal care is not as accessible, babies who are born and not treated for these type of infections can go on to have blindness, pneumonias, blood infections, right? Really, really high risk things for babies. We don't see that a lot here in the US because most of the times they're treated during prenatal care, and those symptoms are terrible for a mom. So she's usually trying to get care for those. And so once the baby makes it through the birth canal and can be treated, overall that baby should do okay, even though they may have been exposed.
Okay, what about herpes?
Herpes is one that everyone worries about, right?
Right.
I feel like I get some calls where people are like, I'm considering fostering or adopting this baby, and the bio mom has herpes. So herpes is an interesting one. If the mom is on treatment for herpes to lower her viral load of herpes, and if she doesn't have an outbreak during the time of delivery, that baby is going to do great, probably, like very, very low risk for anything going on. Now, if that mom is not treated at all for herpes and has an active infection, the medical recommendation is that mom have a C-section, right? And then that baby would be closely monitored after birth. If let's say the baby's born at home or it's just a precipitous delivery that comes out too fast and is born through an active herpes infection, then you really do have to worry, right? And the hospital would make sure that baby got all of the treatment that they needed. The risk of herpes, if a baby acquires herpes, is that it can go into the nervous system and cause meningitis and other really horrible and complications. And so that is there. But again, in our world of good medicine in the United States, those are relatively low. Now, is it possible too that someone has maybe oral herpes and comes in and gives that baby a big old kiss on the mouth right after they're born? Yes. And that's also really concerning, right? So in general, if someone has an active herpes infection, they should be really careful around a newborn.
Which one do you want to tackle next, HIV or syphilis?
Let's tackle syphilis, because syphilis to me is a mean beast. And I hate it because you can treat it so quickly. And I hate that the rates of it are going up in the US. But syphilis to me it scares me. It scares me about the long-term complications for that child.
I would also assume that most moms, if they're getting any prenatal care, and because it's a relatively quick treatment, is it not?
You're right. Yes. If you get good prenatal care, and that's what's great about it. Let's say you get syphilis week 1 and you're treated week 2. Great. That's perfect.
Yeah. So it's a quick treatment. It's not like you're going to have years. But
no, it's very quick. And so that's what maybe makes me so frustrated about syphilis is that as long as you get good treatment, it prevents really challenging outcomes for a baby. However, if you don't know you have it, and the primary lesion of syphilis is painless, it doesn't hurt. And so it can be kind of some people may not know what it is.
Sure.
And so if you don't get treatment for syphilis, especially early on during pregnancy, syphilis is one of these that can cross through the placenta. And so it can lead to congenital syphilis. And congenital syphilis puts you at extreme high risk of stillbirth, preterm birth, low birth weight, miscarriage. significant birth defects or organ damage. And so if that, let's just say the mom during her entire first trimester, second trimester has syphilis, even if she gets treatment, there's still these high risks to that baby.
Okay.
And then if the baby's exposed later on, right, then that lowers your risk of that congenital syphilis kind of syndrome or complications. But most of the time with these, I would say it's moms who have limited prenatal care and they come in and they're positive for syphilis and no one knows how long they've been positive. Right. And the baby's born and there's certain tests you can do to see, does the baby actively have syphilis now? And so the doctors will do that. And it's very easy to treat the baby to clear the infection of syphilis, but it doesn't prevent the long-term outcomes that baby may have already been exposed to. And so when I say syphilis is scary, to me, it's just very unpredictable. And maybe it's the most frustrating for me because when a family will call and say, there's this baby who was born positive for syphilis or mom was positive for this amount of time, I really don't have a great answer for them. And so the advice that I would give is those babies are at high risk of having long-term challenges. They may not have any at all, but you would need to go in, as you said, Dawn, eyes wide open to what that could be.
Okay. The last one we're going to talk about is HIV. And we've come a long way in the treatment of HIV.
Yeah.
But it's still a common STI.
Right. Yeah, I could talk about HIV all day. To me, it's my favorite. I think there's such a stigma about HIV and how horrible it is. And you should be an outcast in society if you have it. I mean, people are still like, ooh, even, some daycares are like, oh, but HIV is so treatable now. We can't cure it. Nobody's figured out how to cure it yet. But with good medication and following up with an infectious disease team, we can get HIV levels to 0 or below a certain level. And you wouldn't even know if you check their blood that they have HIV. And so it's so important for everyone to realize where we have come with this disease. And there are still babies being born who acquire HIV, but their long-term health outcomes and how they do in life is pretty good. And so many people would probably say they're the most scared of HIV, but I would say, let's change that. And let's think about HIV in the way that how treatable it now is. So when I think about HIV, it's fascinating. A mom can have HIV. And my understanding is the highest risk of that baby acquiring HIV is when the baby is born through the birth canal or through a C-section, right? They're exposed to all those body fluids. If they don't receive treatment right away, the appropriate antiviral treatment, their risk of acquiring HIV is somewhere around 25 to 40%, depending on mom's viral loads and when she got it and all of that kind of stuff. If they receive treatment right away when they're born, and typically that's several weeks of treatment with good following up with infectious disease and some blood checks and that kind of stuff, you can decrease that risk to less than 1%.
Wow.
And that, to me, it's so fun to follow these babies. And you just hope, right? Each time they get their blood drawn, you're like, please don't be positive. Let's break this cycle of HIV for this baby and just let this baby go on and have a normal life. But occasionally, one or two of them over several years have come back positive and they're doing great on their antiretroviral treatment. My infectious disease colleagues would say the hardest thing for them is going to be the stigma that they face during their lifetime. Their disease is not going to be the hardest thing.
Interesting.
And so that's just a fascinating thing to think about as an adoptive or foster parent, right? That your biggest support that's going to be needed is just the stigma around that child based on what people assume, which is sad. But I should say, if a mom has HIV and is pregnant, you're still carrying preterm risk, low birth rate risk, delayed growth and development, long-term things. All of those things still fall, right? While this baby's being developed, there's a virus actively kind of around and affecting this mom's metabolism and health. And so that can impact the baby. So I don't want to minimize it. There's still challenges that come, but overall, I think there's a misperception about how scary that disease is.
All right, now I want to shift to mental health issues. And the main thing I want to talk about is what is the genetic connection, or how heritable are these mental illnesses? Because that is information that often people do know about. Sometimes you don't, but usually, it's a question that's asked of birth moms or expectant moms if they know the father of the father. And so the question we get is, what are the chances that the child will inherit this mental illness? So I'm just going to name a few, and if you could just tell me how heritable, how strong of a genetic connection is there. Let's start with anxiety disorders, and that would include panic disorders, obsessive compulsive disorders, phobias, things like that. How common is it for, if a parent, one or both parents, have this, that the child may inherit it as well?
Yeah, these are hard questions to answer, especially on a case by case. But I think the understanding in literature about anxiety disorders is that they are inheritable, but it's not 100% and it's not 50%. It's something lower than that, that if a close family member has an anxiety disorder, the relative may also be predisposed to that. Now, does that person automatically have an anxiety disorder? Not necessarily, but are they predisposed that in the right environmental settings with stress or trauma that could blossom into something bigger?
Yeah.
Potentially so.
You raise such a good point. What is difficult about this, and the reason it is hard to give a hard and fast answer, is that assuming that the adoptive family doesn't have an anxiety disorder, the child is going to be raised in an environment where that disorder is not influencing the environment. And so it's hard to tease out, because much of the research would be the child is being raised by the parent that is struggling with the anxiety disorder. So that's a complicating thing that you have to take into account. Let's talk about mood disorders, which I would include depression and bipolar. What's the genetic connection there?
So for a depressive kind of disorder, I put it in the same category as anxiety, that genetics play a role. You can be predisposed and have a slightly more likelihood depending on your environmental factors. Bipolar disorder is a really interesting one that seems to be much more inheritable than these other types of mental health disorders. And it's fascinating to me, but the literature shows that there's an inheritability of 60 to 85%.
I've read the same. Yes. Last thing I just heard was 80%. Yeah.
Right. Which is, if one parent has it, my understanding, and I might be wrong on this, Dawn, is it doesn't mean the child then is guaranteed to have or an 80% chance of bipolar, right? It's just that it seems to be inherited pretty high.
The predisposition is high. Yes.
Is high. And so, that child might look more like 10 to 20% of a chance. And then, one way they look at this is the inheritance across twins. And so if one twin has it, it's higher risk that the other twin would also have that. So that's a really interesting one.
Yeah. And keeping in mind that if both biological parents have this, then it obviously would increase the chances as well.
Right.
Let's talk about personality disorders, antisocial, borderline, narcissistic. What do we know about those as far as heritability?
So they seem to be kind of in between anxiety and depression and bipolar, which is different than I would expect, right? In my mind.
My mind, it is different. Go ahead.
I think about personality disorders as much more environmental, but it seems that there is kind of a genetic predisposition. And now, I don't know in these studies, are they looking at if one person is raised in one environment that led to a personality disorder, and then their brother or their baby is raised in the same environment, that's already a higher risk thing. So I'm not sure if they tease that out, but I was surprised that it does tend to have a bit more of a genetic predisposition than I expected.
Okay, what about psychotic disorders? And I guess what I'm really talking about is schizophrenia.
Yeah, so schizophrenia is one that definitely has a genetic predisposition. It's similar to this bipolar category of pretty high heritability across of schizophrenia. So it's high. I think the studies show it's about 80%. And then again, if the parent has it, that child then is at a, 10 to 15%. So, and then again, if both parents have it, that puts that at higher risk. And I think we're understanding more in schizophrenia of some actual genetic
Mhm.
where there are actually errors in the genes that make you more predisposed to a kind of schizophrenia type diagnosis.
Mhm. And the last one I want to talk about, I actually don't think of as a mental health issue. Maybe it's because I'm the parent of two kids who have it, but ADHD, it's very common in the adoptive population.
Mm-hmm.
How heritable is that?
So ADHD is quite heritable, which is fascinating. ADHD is hard for me because I think when we talk about the foster and adoption world, these children have been exposed to all the things that we talked about today. There's some amount of in utero something, or maybe preterm birth, or maybe low birth weight, all these things that predispose to possible behavior concerns later on. And then you add in possible trauma if you're in the foster care system.
Mm-hmm. Mm-hmm.
All of those things look like ADHD.
Which complicates it, yeah.
So we're diagnosing ADHD, but what is truly genetically ADHD and what's environmental predisposed? Something happened and you ended up with ADHD is very hard to tease out. But all that to say that if a parent or both parents have ADHD, it's very likely, or that child is at a much higher risk of having an ADHD diagnosis sometime later on too.
Before we continue, I need to shout out a huge thanks to Hopscotch Adoptions. They are a Hague-accredited international adoption agency, placing children from Armenia, Bulgaria, Croatia, Georgia, Ghana, Guyana, Morocco, Pakistan, Serbia, and Ukraine. We have had them as a sponsor for the podcast for a very long time, and we are so appreciative of their support. They specialize in the placement of kids with special needs, in particular Down syndrome, and they also do a lot of kinship adoptions. And they can place kiddos throughout the U.S., and they offer home study services as well as post-adoption services to residents of North Carolina and New York. So check them out, Hopscotch Adoptions. And now, back to the interview. Okay, now we're going to switch to talking about the legal risk factors. It is required that I think in all 50 states, that adoptive parents have a home study and background check requirements. Who does that process?
Yes, you have to have that pre-placement home investigation and post-placement report, usually done by the agency, or can be private certified home study providers in the states that can do that. It's not just any social worker that can do an adoption home study. It's unique. And so families often say, well, I've got a friend who's a social worker or who works for Department of Social Services. I'll have them do my home study. An adoption home study is very different from a foster care license or from any other thing that's called a home study. This is an adoption pre-placement home investigation with unique criteria that's statutorily driven.
All right. Can adoptive parents advertise to find expectant parents who are considering placing their baby?
It's a state-by-state requirement. South Carolina allows it so long as they have a home study. And different states have that rule, but it can be a criminal violation to advertise in some states, and criminal violation if you are not home study approved. So you have to be mindful of that for sure.
How does that work on social media? Is that considered advertising? If you are posting on social media, look, we are looking to adopt. If you know of someone or if you yourself are considering, please let me know. Is that a risk for adoptive parents?
I think if they have a home study and they are approved, I think that's a safe bet. Those laws primarily went into effect where there were yellow pages. If any of us remember those days, when non-licensed agencies, facilitators were advertising adoption services and they were not licensed or accredited or in any way accountable. And those were those groups primarily. But as long as a family has that licensed home study and they're doing that on their own social media, I think that's appropriate.
All right. Can you state the 3 issues that could come up that make an adoption risky going forward?
Yeah, the 3 things that I think are the most significant legal risk issues are 1, the federal law, the Indian Child Welfare Act, ICWA. If the child is a Native American child who's a member of a federally recognized tribe, the rules are just different there. And so that's an important hallmark of legal risk is ICWA. The second is making sure that the requirements of the Interstate Compact on the placement of children, the ICPC, are adhered to, which is this compact among the 50 states that says that both states have to agree before a child can move from state A to state B as a preliminary to a possible adoption. And honestly, that happens a lot.
What are some of the issues under the ICPC, Interstate Compact for the Placement of Children? What are some of the issues that would come up that parents need to be aware of that they wouldn't automatically think of, that they need to make certain that they are adhering to?
Well, it's largely procedural. It requires the sending state to look at the medical and social history, look at the home study, look at all of the documents that freed this child for adoption to make sure that they're done under state law. And then they're also reviewed by the receiving state to make sure, for instance, if this child has special needs, that adoptive parents have a home study that approves them for the placement of a child similar to that child. So that sometimes takes time, and it might be a week, sometimes more, before the adoptive parents are free to return to the home state.
So it's a legal risk technically, but as long as you're following the process, which is well laid out.
Yes.
Right. All right.
Honestly, the biggest legal risk of ICPC cases is working with an attorney who dabbles in adoption and did not recognize the ICPC's applicability.
Okay, that makes good sense. All right, and what is the third legal risk that you were referring to?
Birth father issues.
Okay.
Recognizing that birth fathers have a legally recognized, constitutionally protected right, so long as they have done certain things. And those things usually are defined by state law. But if that man has seized the opportunity that the biological connection afforded him, his consent to the adoption is required, just like a birth mom's. But if he hasn't, the adoption can go forward without his consent. That is very state specific. So in South Carolina, he has to have done certain things. He has to have stepped up, if you will, have been an earnest father. Has he lived with her? Has he offered to? Has he contributed financially? And then the next question is, did he, if you will, raise his hand as the father? Did he register with the putative father registry, which 34 states have, that allows there to be this database where a man who is not named, meaning a John Doe, he's not on the birth certificate, he wasn't named by the birth mother in the consent document, but he can name himself by virtue of registering with this database under the name of the birth mom. And then we check the birth mom's name. And again, it's a confidential database. Not everyone can just go on here and to search these records, but an adoption agency can, an attorney can, to see if a man has claimed paternity. If he's claimed paternity, he's given notice and an opportunity to be heard as to whether he's done those things necessary. If he hasn't signed up, that's usually, in most states, an implied irrevocable waiver of his right to receive that notice.
All right.
So there's no more publications in newspapers and things of that nature. So the legal risk issue is, have we dealt with the birth father in an appropriate way, given him an opportunity to be heard? And if he has done those things, given him the right to be a participant in the adoption? And if he hasn't, it gives us a way to move towards permanency for that child more promptly.
So, what rights do adoptive parents have after a match? They have been matched with an expectant parent. Parents or mom, they've met with this person, they have had a baby shower, they have started dreaming about this child, but the expectant parent's child has not been born, and the expectant parents have not relinquished their rights. What rights do the adoptive parents have?
None.
And that's a hard pill.
That's really why I don't like the term failed adoption, because a failed adoption looks at the adoption from the adoptive parent's point of view and not the child's point of view. It may very well have been the appropriate decision that expectant mom came to, even though she thought about adoption for a while and maybe even committed to it. But she has complete agency. She has the right of making her own decision all the way through to the time that she signs and through the time of that revocation period. And so the adoptive parents cannot assume that that child is theirs or assume any rights until the law bestows those on them.
Well, thank you so much, Jim Thompson and Dr. Lindsay Terrell, for talking with us today about evaluating the risk factors common to domestic infant adoption. I truly appreciate your expertise.